Clinical research in pulmonary fibrosis. What's going on? How can I get involved? And what to expect? New treatment of pulmonary fibrosis. What do the results of the recent clinical trials mean to me? And those two topics are going to be spoken to by Dr. Chris Ryerson, who completed his core clinical training at the University of British Columbia and an interstitial lung disease fellowship and master's degree in clinical research at the University of California, San Francisco, before joining UBC facility in 2011. He is a professor of medicine at UBC, director of the St. Paul's Hospital ILD Clinic and Research Program, and head of the Division of Respiratory Medicine at the Providence Healthcare. His research focuses on the diagnosis, management, and here we go again, prognostication of ILD. He is also involved in several national, international clinical practice guidelines on diagnosis and management of fibrotic ILD. Whee! You got a lot on your plate. Dr. Ryerson.
All right. There we go. I recognize it's just after lunch, and people might be having that little nap time that you want to have. So feel free to walk around, get up, have a little snack, use the restroom. You won't miss anything too important here. And Fran also neglected to thank probably the most important person in the room for this, which is herself. So before I talk, I'd like to have everybody give Fran a big thank you as well. So we've been lucky to have Fran working on this and many other things over the last decade, and really is a fixture in the province of BC, and really a national, if not an international reputation for what she's doing with us as well. So I'm going to give two related talks for the last hour of this, and happy to just kind of go through both. I'm happy to take questions at the end or as we go along, so this can be relatively informal. So feel free to just put your hand up, and if I get frustrated with too many questions, I'll tell you to sit down and we'll move along. So starting with just clinical research in pulmonary fibrosis. So this is kind of what I spend most of my time on, actually. I spend only about 25% of my time seeing patients, 25% of my time doing various administrative chores, and then half of my time doing more research kind of stuff. So that's what I'm mostly going to be talking about. These are all my disclosures, different drug companies that I've worked with or other groups that I've consulted with, and clinical trials we've participated in, and so on. The one probably at the beginning that's worth mentioning is Boehringer Ingelheim, which has supported the registry that I'll talk a little bit about. I'll go through these four main sections for this talk. So I'll very briefly just explain what pulmonary fibrosis is, just so that we're all for sure on the same page. I'll talk a little bit about what clinical research is in general and a few different types of studies. And then I'll go over what clinical trials are currently ongoing in British Columbia right now and why you might want to get involved in research. So first of all, what is pulmonary fibrosis? So this is a picture of a normal lung biopsy showing that really nice lace-like architecture of the alveoli, which are the little tiny air-filled sacs where a gas exchange happens in the lungs. This is what normal should look like. The fibrotic lung, or the scarred lung, at the bottom, these are three different patterns of scarring that we see. And you can see that nice lace-like architecture is, there's a whole lot of pink on these slides, and that represents scar tissue. And that's not what we like to see. That does two main things. One is that it makes it harder to open up your lungs just because scar tissue is kind of tight. And secondly, there's a greater distance for oxygen diffuse across that scar tissue, so you have a harder time absorbing oxygen into your body. So those are the two main consequences. When we talk about interstitial lung disease, it's a big umbrella term, so that's what this gray box represents. Within interstitial lung disease, most of what we see would qualify as pulmonary fibrosis, which just means scarring of the lungs. But that's also a very general umbrella term. And then within pulmonary fibrosis, we have a number of different subtypes. We often talk about idiopathic pulmonary fibrosis, or IPF, and that's just one of the subtypes of pulmonary fibrosis. It represents about a quarter of what we see in clinic. Other common ones that we see in clinic would be connective tissue disease associated interstitial lung disease, or CTD-ILD, and that's a group of autoimmune conditions, and you'll have heard terms maybe like scleroderma or systemic sclerosis, rheumatoid arthritis, myositis, and others. And then hypersensitivity pneumonitis, which, the yellow really doesn't work well on that screen, but that's what that yellow circle is. That's hypersensitivity pneumonitis, which is a bunch of conditions caused by environmental exposures, mold and things like that. How we diagnose patients in clinic, we go through a history, asking a whole bunch of questions of the patients. We do some blood tests looking for autoimmune conditions. We do breathing tests, a CT scan, which is our main diagnostic test. And then sometimes we do bronchoscopy, which is that little camera down into the lungs, or a lung biopsy where we go in through little keyhole incisions to take a little piece of lung tissue out to look at under a microscope. So that's how we make the diagnosis. And if we look at these three cases at the bottom, if we put that together with the CT scan pattern and some of the clinical data that we get from patients, we have different stories and different types of patients that emerge. And those are the kind of classic cases of hypersensitivity pneumonitis, or IPF, or a connective tissue disease. So that's kind of the background, and I'll move on into what is clinical research. So I find it helpful whenever I'm asking these kinds of generic questions now. I have my own idea of what clinical research is, but ChatGPT is really helpful for these kinds of questions nowadays. Does anybody know what ChatGPT is? Yeah, so it's quite simple. So I just went to ChatGPT and I said, hey, what is the definition of clinical research? And it spits out a nice, concise 5-line answer that's probably better than what I would have come up with. There are 3 things that I would highlight from this. So first of all, clinical research is the study of health and illness. It can gather data on the effectiveness and safety of new treatments and medications or medical devices. And the goal is to improve patient care, understand disease processes, and inform healthcare practices. So that's what we're talking about. When we talk about research, we often talk about basic science research, which is in a lab looking at pipettes and molecules and things like that. And then there's clinical research, which is kind of the applied research that we do that has direct application to patients and their lives. So when we think about clinical research, there are some big unanswered questions for our field, and this is specific to pulmonary fibrosis. So we have a relatively naive understanding of the underlying biology of these conditions. And that's something that's really gotten a lot better in the last 10 or 15 years, but we still have more that we don't know than what we do know. We are getting better at this, but we still are lacking some information on what tests are appropriate in what situations, how can we estimate prognosis or predict progression before it happens, what treatments are appropriate for what patients. So far, we've largely been applying treatments in very broad populations, but probably they're more relevant to individual populations for one treatment, and another treatment might be better for that population, and we don't really know that yet. And then there are biological processes that we would like to target with new treatments, but we don't have a great understanding of those actual biologic processes yet. So these are some of the big questions that we would like clinical research to answer in the next 5 to 10 years, hopefully. So types of research, the way that we can answer these questions, I put these into 3 big categories of studies. There are prospective cohort studies, retrospective cohort studies, and clinical trials. And I'll go through what each of these are briefly. So first of all, a cohort is just a name for a group of patients. As doctors, we like to make new names for things that are simpler to describe with other terms, but that's what a cohort is. The thing that these all have in common is that they're all focused on acquiring new data to better inform our understanding of a clinically relevant question. So if we start with kind of the simplest, a retrospective cohort study, what we do with this is we take a group of patients. Right now there are 100 people on the screen here. So that's our cohort of 100 patients. And, we're starting with prospective cohorts, sorry. So a prospective cohort is when we take those 100 patients and we follow them over time. So we don't know what's going to happen to you. We know you've got a condition. For simplicity, let's just say the big umbrella of pulmonary fibrosis. We're going to take you, we're going to collect some data over the next series of visits in clinic. We're going to prospectively follow you and see what happens to you. Some people are going to experience certain events that we're interested in studying, and then we can then compare those patients to people that didn't have the events. So in this example, 20 people turn red. Being red is really bad, and we want to compare that to the 80 patients that didn't turn red. We can learn a lot about a disease by doing that kind of analysis. These are relatively unbiased. They're relatively expensive, though, and they require some effort from patients as well as from the research team. And we often have a hard time proving causation. So we might be able to see that, oh, this group of patients got this treatment and they did better in the end than this group of patients that didn't get treatment, but that might not be a causal relationship. It might just be a coincidence or a biased relationship. So there are some weaknesses of prospective studies. Retrospective studies, we can look at this with the same 100 patients, but we're looking back in time. So we've already seen what's happened to these patients. Some of these patients have already experienced certain events, and we can look back and compare those patients to people that did not have those events. So same kind of deal, 20 people turned red, 80 people did not turn red. We can see what the differences were. The problem with these, or the challenge or limitation of these, is that we often didn't collect the right kind of data way back at the beginning to answer the question that we're interested in answering now. So we have some biases associated with that and a lack of comprehensiveness of our data set. The nice thing about this is that they're quite efficient. We've already got whatever data is necessary. We've already collected that data. Patients aren't typically being asked to fill out questionnaires and things like that. So it's relatively simple for patients to do these kinds of things because we just go back and look at your chart and see what happened. So the Canadian Registry for Pulmonary Fibrosis, or CARE-PF, is one of these prospective cohorts. So we're following people over time. And we do that primarily to do retrospective analyses. So this has a bit of both of the prospective and retrospective kind of part to it. For those of you that have participated in CARE-PF, I'm sorry for the long questionnaires that we ask you guys to fill out. That's my fault. But we have a 12-page questionnaire that we ask patients to begin with at the beginning of entry into the registry, although the first page isn't a full page, so it's not as bad as 12. It's more like 11 and a third. And then we have a 10-page follow-up questionnaire that people fill out when they come back to clinic again. These questionnaires include things like demographics, your address, some of your risk factors, comorbidities, and those we just ask at the beginning. And then at the beginning and at follow-up, we'll ask these patient-reported outcomes, dyspnea or shortness of breath, cough, quality of life, things like that. And then we ask about different treatments for pulmonary fibrosis, as well as oxygen and pulmonary rehab, in addition to the usual medications. So that's what we're collecting from patients who are participating in the registry. From your chart, we also are recording things like your diagnosis and some variables related to that, your breathing test results, autoimmune serologies, CT scan results, echocardiogram results, right heart catheterization results, and biopsy results, and your outcomes. Altogether, we have more than 500 different pieces of information that we're collecting from people. So there's a lot of information in this registry. We started it in 2015. I'm the lead of it, and so BC is kind of the coordinating center for all of this. And we've grown to be the largest registry in the world with more than 6,500 patients across the country. We've had 15,000 patient visits. We've collected literally millions of data points. We've published 40 manuscripts that are all clinically relevant questions that we've asked, and this is the most productive registry in the world as well as the largest. We've got 4 under review and dozens that are in progress and dozens of additional conference abstracts as well. We've collaborated with people from every continent now except for Antarctica. which there aren't that many pulmonary fibrosis researchers down there. So we've got a worldwide reputation for what we've been doing. So we've been very successful, and a lot of that is thanks to our great team, but also thanks to everybody in the room and elsewhere across the country who's contributed their information. We've focused on diagnosis and classification of pulmonary fibrosis, how symptoms impact lives, social determinants of health, so things like socioeconomic status, which there's a whole bunch of other things to that as well, workplace productivity, impact of air pollution on outcomes, treatment benefits and safety, and then various outcome and prognostication kind of studies as well to better predict who's going to need more aggressive treatment and who maybe doesn't. One of the things that we've been good at doing, especially at St. Paul's Hospital, is that we've used CarePF as a hub with a hub and spokes model where we have this core clinical data set and we have collaborators in a whole bunch of different areas. And I won't go through these, but we've been able to branch out into different aspects of things that are important to patients, whether that's exercise or the biology or CT scans or genetics or air pollution and so on and so on. We've had collaborators locally at St. Paul's Hospital. And we're trying to replicate this kind of success across the country so that there is a hub and spoke, not just at St. Paul's, but in Calgary and Toronto and Montreal and so on. So this is the investigators nationally. So these are all the respirologists at the different sites across Canada. We're growing all the time, so you'll see a few familiar faces on the top left from Vancouver. But we have 8 centers across the country with a few people at each center. So what we're doing next for CarePF is we've just set up a community or a patient advisory network because in the past it's been kind of conventional and conventional in a bad way maybe that when we started this out, the norm was for me as a lung doctor to say, okay, this is what's important for us to study, and I go and develop a protocol, and we have lots of productivity from that, and that's great, but we didn't really talk to patients all that much when we were starting that out, other than our usual, like I talk to you guys in clinic and so on. So we're setting up an advisory panel that will help us set our future goals and priorities. We're still interested in more people. If you're particularly interested, this kind of touches back on what Gail, wherever Gail is, had talked about. If you want to get involved, this is one of the ways to get involved with our community. One of the things that we're trying to do as well is expand our inclusion of underrepresented and underserved people. The main way that we're doing this in the near future is by implementing processes for electronic or online consent, so you don't need to come to clinic and read a consent form that's printed out on paper. We would have the ability to do that electronically, which allows us to expand our reach to people that aren't necessarily coming down to clinic to see us each time, people that are being cared for out in more rural sites. And same thing for electronic data capture. So if you loved filling out paper questionnaires, you're going to love it even more filling them out online, which would be able to continue to collect that information longer term with greater ease. And then we're trying to expand biobanking across Canada. So biobanking means essentially what we're talking about is collecting blood from patients, which we try to collect one sample from every patient that we see with pulmonary fibrosis. And we've been doing that at St. Paul's for 5 to 10 years, but we're kind of the only place in Canada that's been doing this regularly. And so we're trying to expand that infrastructure across Canada. And we've had some success. There are 4 or 5 other sites that are starting to do this or have just started to do this in the last few months. And it's the biobanking part that really ties the clinical information that we collect from patients to the biology, which is really how we learn about new treatments, which is really what we're striving for. So the next group of clinical research studies are clinical trials. And I'll be talking about clinical trials for the rest of this time. So clinical trials are where we give an intervention or a drug to some patients in an attempt to determine whether that drug is effective in those patients. So as an example, we give drug A to everybody in green at the top, and we give drug B to everybody in blue at the bottom. Usually, we're comparing a new drug, drug A, to a placebo. which is drug B. But when you go into a clinical trial, usually you don't know which one you're getting. And so that's a placebo, is that kind of old-style sugar pill. It's not really a sugar pill anymore, but that's the idea behind it. And then we treat people for however long the trial is, and then we compare them at the end of that study. These are very expensive, but this is really the only way to prove that a new drug is effective, with quite rare exceptions. There are three main phases of clinical trials. So when we talk about phase 1, the goal of that study is to determine the safety of a new drug, typically in a healthy group of people. So not in people with the condition that we're interested in. We give little doses of a drug to people who are healthy, usually who are young healthy adults, and we give them a little bit more until either something bad happens, and usually, hopefully, it's just a little bit of something bad, and then we give it up to that dose that was suggested to be the right dose based on animal studies that had been done beforehand. So that's phase 1. Phase 2 is only if phase 1 was good. You do a phase 2 study where we're determining the safety of a drug in patients with the disease. We often will get a hint of whether there's benefit. That's what we're hoping for as well, but really the goal is the safety part for a phase 2 trial. And then a phase 3 study is the big one, and the phase 3 studies probably cost around $200 million or so to run. So these are big investments. So a drug company really wants to know that this is a reasonable shot at success before they do this. And the goal is to prove the benefit and safety of a new drug in patients with a disease to the point where the funders, the regulatory bodies, can then decide to approve a new therapy that passes that phase 3 study. These are usually 1,000 patients or so for pulmonary fibrosis, and usually there are a couple hundred different sites that are participating in these trials around the entire world. This is what a phase 3 clinical trial design typically will look like. So we have a person, they come into S, which is their screening visit, and that's a person who's already been flagged by somebody like me and saying, yeah, this person would probably be a good fit for a clinical trial. Let's bring them in and go through a whole bunch of detailed assessments to see if they actually are meeting all the criteria. And I'll go through the criteria in a sec that we typically are looking at. So they come into the screening visit. If they pass the screening visit, they go into the randomization step. That randomization puts them into drug A or drug B. And then we don't know what they got, so they follow the same protocol through visits 1, 2, 3, 4, 5, 6, 7. Usually, there is a baseline visit 1, and then there's monthly visits up until 3 months, and then visits every 3 months up to a year. That's kind of the average, but each study is a little bit different. So this is a fairly typical one. And then the EOS, that's the end of study visit, EOS, end of study. And that's where we say, great, thank you, we'll see you next time. And then after that, we hopefully get a result that looks like this. So this is what success has looked like for previous clinical trials. This is the Impulsis study of nintedanib, or OFEV is the trade name. I should be calling it nintedanib. So nintedanib, what this figure shows is it shows, let's see if my cursor, it's a bit small. So what this shows, the top blue line shows that over 52 weeks, there is less decline in that blue line compared to the gray line that you can't see. So I'll yell loud and kind of show everyone. So this blue line is closer to this dashed line. If you're at this dashed line, you're perfectly stable over the last year of this study. So the closer you get to here, the better. The placebo group is down here. You can kind of see the hash marks here. So we had about 50% reduction in the rate of progression with nintedanib compared to placebo. Does that make sense to everyone, more or less? Okay. So this is nintedanib. Pirfenidone works just as well. I just happened to show the nintedanib one because the next part of the story relates more to nintedanib. But pirfenidone works just as well. This is specifically for idiopathic pulmonary fibrosis. I'll come back and touch on this a little bit more. So moving on to active clinical trials in BC, a couple quick caveats are that St. Paul's and VGH are the two main study sites in BC. There are sometimes one or two other sites that will enroll patients for one trial maybe, but typically it's St. Paul's and VGH. We will share patients back and forth, so if there's a study that you're eligible for at VGH, I know which studies are going on over there, and if we don't have a study at St. Paul's that makes sense, we can ship you over there very easily. If you are interested in a clinical trial, you can ask your respirologist if they think one is appropriate, and we're always happy to chat with people about that. Typically what I require is that patients be referred to me, and I see people in clinic, because I would say probably, I don't want to be too pessimistic, but probably 80 to 90% of the time when a patient wants to participate in a clinical trial, there actually isn't one that's really that relevant for them. That might be a little pessimistic, but it's necessary for us to see that person and get all the details before we just go full on into a clinical trial setup. So these are the IPF clinical trials in BC. So again, remember, IPF is only about a quarter of what we see. But we've got 6 different clinical trials that are going on or just finished or are just about to start in BC. These are all antifibrotic medications. They all target different pathways that are involved in the generation of scar tissue in the lungs. I'll talk about the top one in a little bit, but you can see all of these studies are between half a year and a year in duration. They're all different pharma companies. Most of them, well, half of them were at both sites. So we've got some overlap between what's going on at St. Paul's and VGH. Mostly these are comparable studies, so I don't really have a huge preference for one over the other. It often comes down to patient preference really between these. These are the progressive pulmonary fibrosis clinical trials. So these are not IPF, but these are other subtypes of fibrosis that are progressing. So if you have that hypersensitivity pneumonitis, an autoimmune condition, unclassifiable interstitial lung disease or others, and you're progressing, then these are the studies that are potentially appropriate for you. And again, these are all antifibrotic medications, and these all have either already been studied in IPF or they're concurrently being studied in IPF. So IPF is kind of like the first, I don't know, canary in the gold mine, if you want to call it, or that's the first kind of entry for a new trial. We study it in IPF, and then we study it in other conditions. And there are some reasons for that. Some of those reasons make sense, some of them don't. There are 2 cough clinical trials that are going to be enrolling, one already that's enrolling, and then one that will be coming up in the not too distant future. These are slightly shorter studies, and these medications aim to target either the brain receptors or the lung receptors that are involved in the cough reflex. So if you have a bad cough, one of these is just for IPF, one of them will be IPF or progressive pulmonary fibrosis as well. If you have significant cough, then these trials would be potentially appropriate for you as well. And then we have a couple of studies looking at diet and oxygen and exercise. These are just being done at St. Paul's Hospital. They require, one of them requires a lot of visits to hospital to do an exercise program. That's a HOPE IPF study. And then there's another study looking at dietary nitrate, which you can, you'd have to eat so many beets that you would turn dark purple, but there are pill forms that you can take for dietary nitrates, which is theoretically supposed to help improve how your muscles handle oxygen. So there's some interesting studies here. So if you're interested in exercise or potentially diet type stuff, these are studies that might be appropriate for you as well. So the type of patients that come into clinical trials, it's a little challenging sometimes, and it's hard to explain this sometimes as well. So trials need to study relatively homogeneous groups of patients. If there's too much heterogeneity, there ends up being this statistical noise and bad stats happen. And then you end up not being able to prove that a drug works, and that's not good for anybody. So we end up having to enroll patients who meet relatively specific criteria. And the ideal trial participant is somebody who's likely to get worse without treatment, but not that much worse. We don't want to bring people in who unfortunately are so close to passing away that they're going to pass away before we have a chance for the drug to work. So you can't be too severe. We also don't want people that have been coasting along for a decade with no progression, because then we can't prove that a drug works if you're already stable. So there's that middle ground that we want to try to meet. We also have to have the absence of other major complications or comorbidities from other medical conditions that might impact your ability to participate in that trial as well. So these are some of the common inclusion criteria on the left in green and exclusion criteria in the right in red. So we need a diagnosis of IPF for the IPF trials, or meeting criteria for progression for the PPF trials. You have to have lung function, your FVC or your DLCO above certain thresholds. Almost every study now, at least the IPF studies, require a central CT scan to be interpreted. So you do a CT scan at St. Paul's, but we ship that CT to some radiologist down in Denver or London, England, or wherever else. And that radiologist says, okay, you did a good enough job, we can call this IPF. Or they might argue with us and say, nah, you don't quite meet criteria. There's a lot of nuance to that, and that's one of our frustrations around the world with these types of studies. For the cough study, there's a threshold of cough that you need to have. Obviously, we don't want to treat you with a cough medication if you're not coughing, so there's a cough rating scale that we ask patients about. And then we often exclude patients based on lung function criteria. I won't go into the details of that. If you have significant emphysema or COPD, some medications just can't be used with the new medication being studied, or other major medical issues, recent infections, exacerbations, if you're on a lot of oxygen, if you are going to get transplanted in the very near future, any of those kinds of things would take you out of the running for a clinical trial as well. In our registry, only about half of patients with IPF meet these types of criteria for a clinical trial, and in reality, it's half that would meet the criteria, but there are probably another bunch who live too far away to participate and don't want to travel, or they just aren't interested. So we end up having a minority of patients with IPF who would participate in a clinical trial, and it would be less for people who have other types of pulmonary fibrosis. So why should I get involved in research? I meaning you. So this is another great one to ask ChatGPT, and ChatGPT gave a really nice answer. So participating in a clinical trial can offer several benefits. So access to new treatments. So sometimes there is a new treatment and it's the next great thing. That's one that's a little optimistic, but that's one potential motivating factor for some people. You do get monitored much more closely if you're in a clinical trial. You're coming to the clinic frequently, you're getting breathing tests frequently. If something bad is happening, people are paying attention to you relatively quickly, partly because we're worried that we're doing something bad to you, but that does allow us to pick something up along the way. You get to contribute to science. So this is the altruistic kind of part. You're helping people around you, you're helping the next generation, whether that's your own family in 20 to 30 years, as your own family gets older, or other people around you, that's contributing to science. This is sort of related probably to the close monitoring and the access to new treatments, but there's a potential for better outcomes from those treatments. You get additional support services. You might get more access to counseling or education about your condition. And it gives you a better understanding of your health and your treatment options. ChatGPT is pretty good about this kind of stuff. It says if you're considering it, discuss the specifics with your healthcare provider to help weigh the pros and cons based on your individual situation. So it gives some of that nice context as well. So how can I get involved? How can you get involved? So I would say, first of all, you already are. You are involved by being here today. I gave most of the slide last year, if this sounds familiar. You're involved by being there for somebody else, and I think a lot of you are involved in sort of formal or informal peer support networks. You get involved by sharing your story, again, as Gail had nicely described. By raising awareness of research in general, and by supporting research by contributing your data or encouraging others to contribute their data. And then by talking to your physician about research. So if you're being cared for somebody who's not at one of these research settings and you're interested in research, just ask them if it's right for you. And they may be able to say definitively it's not appropriate in your situation. But if there's any question, we're more than happy to see you at one of the research centers. And then, of course, by participating in research yourself. So with that, I'll stop this first part and say thank you. Thank you to everybody who's worked across the country with us. Thank you to you guys who have participated in helping form our bigger network. And I'll stop here for the first part and happy to take questions or just jump into the next bit as you wish. So thank you. Yeah.
If a person has idiopathic pulmonary fibrosis, but doesn't respond to the 2 fibrotic medications, but is subjectively showing improvement with mycophenolate, does that mean that you could have an incorrect diagnosis? And I'm not being put you on the spot, but can you have both? Hypersensitivity pneumonitis and IPF?
No. Yeah, they're basically mutually exclusive diagnoses. Yeah.
I was just wondering, you're saying that when you give the placebo, you don't know you have the placebo, even the researcher doesn't yet at the end of their trial?
Yeah.
But you must have an inkling as they come in for their...
It depends on how bad the side effects are. So if you have horrible side effects of a drug, yeah, I can get a sense. But hopefully we don't tell until the end. And there's enough variability in individual progression that you have to look at averages. And just because somebody did worse a little bit over the last year doesn't mean that they got placebo. If they were stable doesn't mean they got drug. That's why we have to study 1,000 patients rather than just a few. Yeah.
What if you go in a trial and you start to go downhill rapidly?
Yeah.
Like, do you take the person off the trial?
Yeah, so it's a good question. So I would say that there isn't a single answer to that. There is nothing that requires you to stay in a trial. It is always your decision if you want to stop the trial. There are sometimes situations where we will make you stop the trial, but you can always stop it yourself as well. So the reasons that I might say, or that the drug company might say, you have to stop the drug. Let's say your liver gets really inflamed by a drug. We're not going to keep giving you the drug, even if you want us to, because we could kill you by doing that. So there are sometimes stopping rules that we have to follow, that we should follow, but it's always your decision. You don't have to take the drug if you decide that it's not in your best interest. And I would also say that it would be unethical for me to keep somebody in a trial if things are going poorly. It's unethical for me to keep you in a trial if there is any other option for me to treat you with something else. So we always have the ability to withdraw you from a trial to pursue those options. There may not be other options, but if there were, we would pursue those, and no drug company is going to tell me that I can't give you some other treatment that I think is appropriate for you. Okay, maybe I'll move on to